This is a summary of digoxin slides and a case, and our objective is to understand the pharmacokinetics of digoxin and therapeutic range. Then we're going to go into how we can evaluate patient characteristics and disease states so we can recommend the dose or adjust the dose. Digoxin is not commonly used these days, but you will see some patients who are taking digoxin for years, and you want to know how to interpret a level if it is there, or how to identify any side effects that may appear. So evaluation and dosage adjustment, as well as monitoring parameters. As you know from previous lectures and other courses, the mechanism of action of digoxin when it is used for congestive heart failure or AFib. Basically, it's positive inotropic action and negative chronotropic actions. The pharmacokinetic of digoxin are illustrated in this page here, and this is a copy of what we have as required textbook. And basically, the therapeutic range is 0.5 to 0.9 or 1 microgram per liter. And here is a difference. This is the first level that is measured in microgram per liter. If you recall, all anti-epilepsy agents are measured in milligram per liter. Lithium is measured in milliequivalent per liter. Okay. Higher level may be required for AFib to control the rate. Digoxin is available as tablet, where the bioavailability is 0.7, and also available as elixir with bioavailability of 0.8. The soft gelatin capsule bioavailability is 1. The salt fraction is 1. The volume of distribution is very unique in the case of digoxin, where it does not only depend on the weight of the patient, but also depend on the creatinine clearance. We normally use the ideal body weight for digoxin calculations. Clearance in a patient with non-CHF will be a little bit faster than patient with congestive heart failure, and the equation is there. The average half-life is about 2 days, so it takes up to 2 weeks to reach steady state. And of course, if a patient is having renal dysfunction or receiving amiodarone, the half-life will be longer than 2 days. You will need to also look for other drug interaction or disease interaction. Hyperthyroidism and hypothyroidism are very significant factors that affect clearance of digoxin as well. Digoxin is available as tablet 0.125 and 0.25 milligram, which are commonly used. We used to use 0.5 milligram in the past a lot. You will rarely find patient on 0.5 milligram per day. It's also available as IV. This page, the purpose of having it, or this screen or slide, is really to let you know that there is a lot of research that were done to identify different population parameters in different patient population. As you see there are also different equations to estimate the clearance or volume of distribution as compared to the previous slides. I don't need you to memorize any of this population value. I just want you to be aware that it vary based on age, based on disease. Patient with renal failure or congestive heart failure will have different values, And volume of distribution, as I mentioned before, will depend on patient kidney function. The dosing normally start with 0.125 or 0.25 milligram per day, and most physicians now, if they start, they would start at the lowest dose, 0.125, get a level in 2 weeks and take it from there. You most likely not going to see that. What you will see is a patient on digoxin already for a while. The dose is adjusted based on the blood level, and there are not really many dosage alternatives, and that's limit your ability to use different pharmacokinetics when you try to adjust the dose. When you assess a patient, as we discussed previously, you look at the efficacy of the drug, is it working or not working, and any concentration related side effect. With digoxin, it's very classic side effect profile, which is divided into 3 categories: GI side effect, CNS side effect, and cardiac side effect. And in the Board of Pharmacy examinations, it used to be a common questions that students encounter that is related to side effect of digoxin. You may still see it. And GI represented by nausea, vomiting, and pain, or CNS side effect as dizziness, headache, fatigue, weakness, or sleep disturbance and visual disturbance. Cardiac side effects, basically any kind of arrhythmia you may see. Cardiologists will tell you to pay attention to AV block and ventricular tachycardia or arrhythmia. So dose is 0.125 or 0.25 milligram per day. GI side effect, CNS or cardiac. Dose adjustment based on levels. Okay. Disease and drug interaction. The first drug interaction set impact clearance, and this is from drug like verapamil, amiodarone, and so on. The second set of drug interaction affecting or disease interaction affecting clearance is the state of thyroid function. Okay, hypothyroidism decrease clearance, hyperthyroidism increase clearance. I don't need you to remember the percentage, you just need to know if it increased or decreased. Also, drug affecting the bioavailability is very significant in the case of digoxin. For example, antibiotics, broad spectrum, will reduce the intestinal metabolism of digoxin by the gut bacteria. So there is less to be absorbed. When the drug metabolism by the bacteria is decreased, then in a normal person you expect more metabolism happening by the bacteria, which means less bioavailability. So if you're destroying a lot of the bacteria, then you're going to have more bioavailability, and this way more blood levels. Antacids and some other drug, including St. John's wort, will decrease digoxin absorption and blood levels. Drug-induced hypokalemia is also very significant interaction that you need to be aware of. Why? Because the state of hypokalemia will increase the cardiac muscle sensitivity to digoxin, and in this case you will see more side effect, dose-related side effect to digoxin, even at normal level or at higher normal range of the normal levels. The managing of acute and chronic toxicity will be by using immune digoxin fab, dizobine. And the treatment of toxicity is really based on the science, as you don't treat a level, you only treat when there are signs and symptoms of overdose. And in cases of acute digoxin toxicity, we normally estimate how many vials based on the digoxin concentration that is measured, utilizing the equation in the slides here. Okay, what you need to be aware of is that digoxin concentration need to be measured at least 6 hours after drug intake. Okay, because during these 6 hours the level will not reflect reality, since digoxin it take about 6 hours at least for full distribution phase to be complete. And this happened because digoxin behave as in a 2-compartment model. Okay, not 1-compartment model where you may not need to wait for more than an hour to get blood level that will represent complete distribution of the drug in the body. In case of chronic toxicity, the recommendation as per the package insert and the pharmaceutical research is that to go ahead and give 6 vials of immune digoxin fab. And for infants or children less than 20 kilograms, we only give 1 vial. What is significant to know is that when you give digoxin, immune digoxin fab, it will interfere with digoxin level, so you don't monitor the level. You just immediately or within a day or 2 even, you just wait like 2-3 days, you monitor the sign and symptoms of toxicity and you treat asymptomatically. Okay, until the patient become asymptomatic. Selected disease interaction: renal failure will decrease elimination. Neonate have lower elimination as well, but they tolerate high level of digoxin better than adult. Okay, hepatic failure, cardiac failure, hypothyroidism will result in also reduced clearance. Hyperthyroidism increase clearance. Okay, elderly have reduced clearance. So basically everything you see here has reduced clearance except hyperthyroidism. These are 3 very small short articles, and the first one is, I believe, has a video in it that I really highly recommend you to read this article. It's like 1 page or 2 pages, and they are available for Medscape. The first one addresses the management of digoxin toxicity, and the second one is about how mortality went up in a study when they evaluated the use of digoxin in patient. Now here is a case, quick case on digoxin therapy. And again, I don't want you to know a lot of calculation, but I just want you to practice it. I'm not going to ask you to calculate anything related to digoxin in the exam. We have a patient here, an elderly, with high serum creatinine and low potassium. The normal potassium, as we said before, it ranges from lab to lab, but easy way to remember is between 3.5 and 5.3. Some labs report 3.6 or 0.7 to 5.6. In anyway, the way I recall it myself is 3.5 to 5.3 for easy memorization and recall. The patient came to the ER very weak, incoherent, after doubling his own dose. So apparently it seemed like he felt that digoxin is not working. He increased the dose from 0.25 milligram per day to, he increased it from 0.125 to 0.25 milligram per day. He lives alone. no known medical history or medication, and the physician need your input. Physician question may be vague. He just asks input because, or she asks input because the patient is vomiting, having depression, suicidal ideation, hallucination, vision problem, and arrhythmia. In this case, information is limited and you just need to work with what you got. So let's see what's our assessment on this case. The first thing is patient 68, that's elderly, has low kidney function. The second thing, his serum creatinine is 2, that's high, and this means he definitely having some renal dysfunction, which will result in accumulation of digoxin levels. The potassium is low, hypokalemia, increased sensitivity to digoxin level, which increase signs and symptoms of toxicity of digoxin at normal dosage and at normal level as well. He was brought to the ER very weak. Oh, that could be from digoxin, or could it be from hypokalemia? Look it up, hypokalemia and weakness. Incoherent, oh, that's more of digoxin toxicity. He live alone, no known, so we don't know about what drug interaction or disease interaction exists. We know that he has some kind of kidney damage. He has vomiting, that's sign of digoxin toxicity. Depression, suicidal ideation, no, so maybe he has other mental illness. Hallucination, the same thing. Vision problem, classic digoxin toxicity, and the same for arrhythmia. So let's see what we can work on and what we need to address. Number one, do we order digoxin level? Yes, we can. It's a chronic case. He changed his dosage for 2 weeks, so maybe he reached steady state by now, hopefully. If he ingested an acute overdose of digoxin, then we needed to wait at least 6 hours after the knowledge of when the drug was given. But in this case, it appears that it is chronic. Okay? Would you wait for the digoxin level to come back so you can decide on treating the patient with antidote or not? You don't, because the decision to treat is really mostly based on clinical situation, and the patient is having arrhythmia. So some physician will say, go ahead and treat the patient with digibine. Some physician may say, well, let's treat the arrhythmia first and wait until blood level come back and take it from there. Nothing is really better than the other. It depends on, as a decision, it depends on how bad the ventricular arrhythmia is, but it looks like it's classic overdose. I personally would recommend using digibine. How much? You go back to the slides and look it up. 6 doses, 6 vials or less, or would you calculate it based on the level? So I will leave this to you. What's expected digoxin level assuming population parameter? I'm not going to ask you this in the quiz, in the exam midterm, but you can do that. You can find out what is the expected level, because you can find what is the population clearance in this patient, divide the dose over clearance, you get the expected level. Of course, you will consider the tau, the units, the bioavailability, F is 0.7 in this case, and so on. So you can do your exercise to say, well, I predict digoxin level to be X. Sign and symptoms, we talked about this already. Nausea, vomiting, weakness, and visual disturbance, as well as arrhythmia, are classic signs of digoxin toxicity. The other one, we don't know, we are not sure. And also, the hypokalemia may be causing some arrhythmia as well, so you can just check this out. Lab abnormality in this patient, we discussed that. Kidney function and hypokalemia. Its impact on drug therapy. Hypokalemia will increase sensitivity to digoxin dose or level. What do? We need to see why hypokalemia is there. Are there any other drugs the patient may be taking that causing this? But we need to correct it if we see signs and symptoms of hypokalemia. And the same thing with digoxin, we need to act upon it. Then the important thing is that we need to counsel the patient, not to change the dose in their own. The patient may have had hypokalemia first, or his congestive heart failure may have deteriorated by itself, so he decided to increase the dose. So which one happened first? Or did he have sign and symptom of digoxin toxicity initially at 0.125 and he had nausea and weakness, then he decided to increase the dose. Then the problem escalated and he started having more incoherence and arrhythmia. And that's what you would need to investigate above and beyond doing calculations or doing kinetics. You understand the kinetic principles and how the drug is deposited. Then you take it to the next level. You develop treatment strategy. If you're going to continue digoxin on that patient or not. And if you need to provide counseling and social support and find more about the patient. And if you will continue digoxin or not, what do you monitor and when? And this is similar to what you may see in real life or in the midterm. I hope this covered digoxin. Thank you and good luck, and see you next week.